I'm here for the Ozempic. Tell me what's going on.
Yeah. So I thought you guys, you caught my ear because you're chatting, and then I think the conversation kind of went to like, well, why do people even need it? What's the point? Like, what if we just, do training? And I can't remember if it was you, PJ, or you, Grant, who had said like, well, I think of it as like, from what I understand, as a crutch to help kind of just move the process on. It's like a tool to use while you're moving forward, trying to get more fit, lose weight, things like that. And as at basic level, that's pretty much what they are. They're great weight loss drugs. There's a lot of other weight loss drugs. I won't really get into those, but like the Ozempic type medicines, they were big initially for diabetes. And then one of the side effects was it makes you not want to eat so much and it makes you lose a lot of weight. So then everybody was like, well, we can use these for weight loss. And a couple of them have recently been approved for weight loss. And so really the main reason like a primary care doc like myself would use them outside of diabetes, especially if I had an appropriate case, they've tried other medications. They've got we've got actual documentation that they've done the diet, they've done the exercise stuff, and it's just not working, would be to help promote the process and kind of lubricate the wheel to get them moving. It's not necessarily something I'd use forever, where sometimes in like diabetes, we may use it for a long period of time. For weight loss, it's more to stimulate that progression to get to a point where we're making the change and our body is kind of almost like shocked to get back to a point where we're eating appropriately, but we're also losing weight or we're keeping weight off. And so that was kind of what sparked my interest. And so the way they work is you've got GLP-1s, which are like your Ozempics, your Trulicity, some of the others that aren't as common. They work basically to slow down our body's own process of making glucagon, which basically tells the body that, oh, we're starving, we need sugar, liver, make sugar. And so the liver will make a lot of sugar. And in obesity and diabetes, those processes can be a little skewed. So you're making a lot of sugar that you really don't need, but your body is thinking that it's, in like a starvation or a stress state. Some other things it does is it increases insulin, but it increases insulin in very interesting ways. It targets certain tissues, like the liver, like skeletal muscle, like some other tissues, to actually take in sugar. So take in the glucose from the blood. Yeah. And so that's how it works really well, by decreasing our blood sugar. And so that's why it's super effective for diabetes. We can see what's called an A1C, which is like a 3-month average of the blood sugar. It has a pretty good drop in blood sugar over 3 to 6 months. But then that's why it also works in obesity, because it drops our blood sugar, not to a point where we have dangerous side effects necessarily, but it lets our body utilize that sugar as an energy source a little more efficiently than what our body is used to. Some other ways, which are pretty common side effects, is it slows down our GI motility. So food just doesn't move through as quickly. That helps make us a little more full. It also signals the brain in certain ways, to essentially tell the brain like, hey, we're not hungry. We're actually full. Stop sending these hormones to tell us that we're hungry. And so with all those aspects, that's how these medications, from like a basic level, that's how they work. So they target several different ways.
So more than just making the person not want to eat, which was my kind of my very preliminary research, but I was thinking like, hey, it's a brain signal to like, don't release hormones, don't eat. But you're saying there's more things going on physiologically that are also positive in terms of helping with weight loss or lowering blood sugar in diabetic cases.
Right. Yep. Exactly.
Yeah. Okay. So it's kind of twofold. So what kind of person, so I get the diabetic person, but you get an obesity person and they come in. Well, one, like, how does an obese person come in to see the doctor? Do they come in and just am like, do they come in because they have other issues because they're obese? And then you look at it and say, hey, your main issue here is you're obese. Like as a strength coach, someone comes into my gym, they're like, I have tons of back pain. I'm like, hey brother, deadlifting will help. You're 80 pounds overweight. Like I guarantee you that is like your number one contributor to why you have back pain all the time is you're carrying this extra stuff around. So are you treating, when people are getting prescribed it, are you treating the obesity or are you using it because the obesity is causing other things that you're concerned about, or both?
Yeah, a little bit of both. So when people come in to like my clinic now, I only see like dependents of active duty members, certain populations of active duty members, and then retirees. So I don't see like the civilian aspect per se, but the people I see aren't necessarily active duty, if that makes sense. But usually, for the most part, they'll come in and it is more like on an annual physical type basis. Like, we're kind of going through stuff. We're going through preventive measures, but hey, we've got the blood pressure issue. You're on medicine for your cholesterol. This is what your BMI is. I've noticed your body weight is steadily increasing. What are you doing to, to kind of combat that? Which I usually ask people, what is your diet on a day-to-day basis? What are typical foods you often will eat or cook for yourself? What's your exercise look like, if any? And then sometimes I'll get people that are like, you know what? I'm interested in trying to lose weight. How does that conversation look? And usually it'll start with nutrition and diet and exercise. And then I'll usually have them come back after a few months to see if they've made progress. And then after that, it'll just kind of, depending on, what progress they've made, if any, I'll have them come back. And that's where we may potentially talk about medicine. It's a little tricky in the military. You can't just jump to like your Ozempic or things like that. You have to trial, I think 3 to 6 months of diet and exercise, and you have to show and document that that's failed. So essentially just like no weight loss.
Right.
And then after that, you have to try 2 other medications for 3 months, document that you failed those before you can get to those Ozempic type medicines, those GLP-1 agonists.
So, and I want to turn it to these guys here in a second because I know they'll have a bunch of questions. But so you get a person that comes in and let's say it's a retiree, they're obese or overweight, and you tell them diet and exercise, or they tell you what they eat. Because I'm always curious on like human behavior, right? Because I'll get people that come in and they say, hey, I want to lose weight. I want to get stronger. I say, hey, well, tell me what you're eating. And they're like, well, in the morning I eat overnight oats. And at lunch, I eat some rice and chicken and broccoli. And for dinner, I usually have like salmon and a salad. And I'm like looking at them and I'm thinking, nothing you said to me is true, or that's all true. And you also had 3 cartons of ice cream or whatever it is. Right. But like, it's easy if you're someone that trains and eats, for health to know, is that tough? Or do you see that where people come in and they tell you, or I'll just layer questions on, you can run with it. Or you tell someone, they tell you what they're eating and you say, hey, make this adjustment, add this exercise in, come back in 3 months. And they come back in with documentation and say it's failed. Is it like, oh man, like do you ever feel like you weren't doing what you said you're doing? Or, you know what I mean? Like, is that like frustrating or like, what's that process like before you even get into the medication side?
Yeah. Yeah. So usually, when people come and talk to me, I very rarely so far had the suspicion that somebody was just like, oh yeah, I eat nothing but, lean beef and protein and vegetables and berries. And I've cut out all snacks. Like I've maybe had 1 or 2 people that I was like, this seems suspicious. Most of the time people just flat out, cause you're at the doctor, you've wasted, you've spent enough time to get there. They're usually like, well, I might have a bowl of cereal and then I usually will go get takeout for lunch, or I'll pack a ham sandwich. And then dinner time, usually it's hectic with the kids. So we get takeout or we get fast food real quick. So oftentimes I feel like I just don't have time to cook. That's usually the conversation. And then when I have like weight loss specific appointments, which is one nice thing, I'm able to kind of organize my clinic, and I have a lot more weight loss patients than a lot of my other colleagues do. So those usually will be a little more specific. They know what they're eating for breakfast, lunch, dinner, because usually the way I'll start the conversation after trying to get an idea of where people are starting with a baseline is, these are the foods I recommend at these meals with these added things to it. And I also recommend using something like MyFitnessPal, where you can enter literally every ingredient and run with it. And you can save meals, you can do this. And that's usually how it'll start.
Okay.
It's kind of 50-50 on how people then follow up. Either, no changes made, or they've made decent to drastic changes, and, we've got something to run with.
And do you find that most people are ignorant of how bad some foods are? Like, that's kind of what I have found is, they'll explain things like some of that is truthful. Like, well, I'll get, I'll have chicken and I'll get a side of ranch, or, and I'm just like, wait, let's talk about the ranch for a second. And like the nutritional benefits, none. I mean, I guess some calories, right? But like versus, everything else you're getting. And I'm always kind of blown away. And maybe it's just because I've always been interested in health and fitness, and I've been on MyFitnessPal so much or help people. But do you find that a lot of time it's like people just don't know some of the decisions that they're making, like how bad those foods are? And it's not, it's not like, it's just ignorance. Like they just have no idea.
Yeah. Yeah, definitely. Because a lot of people, that's not something that's in their repertoire. It's not something they were really ever told to go do. So exactly to your point with the ranch, you see people very commonly, I eat nothing but salad and, a bunch of vegetables and chicken. And then you do a little more probing, and it's like, well, what dressings are you putting on? How much ranch? It's okay to have maybe a little dabble of ranch if you've accounted for it, but are you just guzzling the ranch down? Are you guzzling, the vinaigrette and butter down? How does that all work? And I would say probably 90% of my weight loss conversations, it usually ends up with I had no idea. Like salad and cereal seem to be the biggest contributors. But yeah, people, they just don't necessarily look for it, or if they do look for it, they don't necessarily what specifically to look for. And they don't break that down or understand like, okay, yeah, sure, your carbs might be low, but you really have to pay attention, like how much added sugar then is in that. And so that's kind of where then I come in and we break a lot more stuff down.
Yeah. Okay. So I have one more question before let these guys hop in here. So one, I find that super interesting. I always think that salads are the worst, and they're not, right? Like it's not like a salad's evil, but it's people actively trying to do the right thing. It's people on a business trip, they're trying to like, I got to have a business lunch, and, it has walnuts in it and raisins and like all these different sugars in the dressings. And I just always think it's interesting that people think like salad healthy. And it's like, like you would have probably been better off eating a burger and getting some protein and like having some carbohydrates than all that stuff. But back to they get to the point where you prescribe Ozempic, or, something of another name. One, how long is it until they see results? And then what happens? So stuff's happening, in the liver and, through the GI system, there's brain things happening, making people not hungry. Then do they start making behavioral changes because of these things and start eating well? Or are they just eating way less? Or if both, is when you take them off it, do you see like a huge increase in weight or habits being built? I guess that's my interest. Cause I always think, hey, all of this, maintaining a healthy body weight for your life is a lifestyle, which is habits. So what is the success rate as far as that goes, or, run with that a little bit?
Yeah. So the Ozempic medications are very effective in weight loss and pretty quick weight loss. Most of the studies that I've read, they claim that the average weight loss within like a 3-month period is actually pretty minimal, maybe 5 to 10 pounds. But anecdotally, the patients I've seen, you can be looking at 15, 20, 30 pounds of weight loss pretty quickly, like within 3 months, which, is not necessarily something I shoot for. I usually tell people, look, 2 to 4 pounds in a month is pretty sustainable, and you're going to be able to keep that over the long term. But these medications are just very effective because we've got they help the body burn fat. They help the body utilize blood sugar. they also make you not want to eat very much. Like if you ever talk to somebody who takes Ozempic or Trulicity, Mounjaro, any of those, they get full very quick. And if they eat too big of a meal, like they will know to the number of bites, how many bites of something before they get nauseated to the point that they may have to go vomit or, just miss a couple meals. That's how effective these medications are. And so usually people do, because that's not necessarily something you want in the long term, people do build some pretty decent habits out of them. However, I've seen plenty of people with how popular they are. Their habits are terrible. They may, eat minimally, but then they try and have a big meal and they're like, look, I don't know why this medication makes me nauseated. I'm vomiting constantly. I can't tolerate it. It's like, well, that's how the medication is. We talked about this when we first started it. You can't eat big meals. Small, frequent meals are your friends. Not big fatty meals can cause this. Heavy carb meals can cause this. And so those are the conversations I usually try and have with people, or if I've got somebody who's on it already and then I'm seeing them for a different reason, I usually try and have that conversation just because the medications are so effective and they have a lot of great health benefits that I don't necessarily want somebody to be on it, have all those symptoms and think, no, this medication's garbage. I can't tolerate it. I need to get off, or I need to try something else, because every medication in these classes has those side effects to a certain degree. And so usually the way we can do that is instructing them on, the small meals, educating them. And then we usually will start at the smallest possible dose, titrate up every week until we get to a certain point. And then from there, every couple weeks or so, we can titrate up as tolerated. If they notice, hey, I'm still eating small meals and I'm still nauseated with this dose increase, we just go back down and we keep that a little longer until the body gets used to it. I've never had a patient who was on it long term and still had those side effects, provided they followed the appropriate educational instructions we gave them, provided we were able to titrate as tolerated. And so that's usually how we go around it.
You guys have thoughts?
Yeah. I have a question. So I want to talk about the how you think about making a decision to look into this in terms of cost and benefit, because I'm not have to tell you this, everything that we ever do is just kind of a cost benefit thing. So on one hand, I think, well, if these are so effective and this is such an effective drug, this is a serious question. Why would we not put anyone who's 10 pounds overweight or more on Ozempic? Why not just automatically do that? And then on the other hand, if there's serious side effects, why not save this medication for anyone who's 400 pounds and over or something like that?
Right.
And so it's not really that the medication is good or bad. It's like, well, you're weighing a risk and reward. And so I imagine that for some people, it's like, hey, this is totally not worth it, man. You should probably just easy on the ranch, And then another person is like, hey, yeah, diet and exercise is great, but you're in a critical situation and we probably need to add this into what you're doing because you're in trouble and we need a quick fix. So how do you think about that, weighing those costs and benefits?
Exactly. And the way you kind of broke it down is pretty on point. In medicine, we have to do a lot of triaging to figure out, even on the battlefield, who is the most injured, who needs the most acute help right now. Similar kind of thought process goes through with a lot of these chronic diseases. Now, if we throw out the diabetes aspect for these medications and we're just looking at weight loss, there's only a few that are approved by insurances for just obesity. Now, if you have diabetes plus obesity, it's pretty much take your pick. Then it just becomes to okay, do we have shortages? What do we have to do from that standpoint? But with just weight loss alone, there's only a few that are approved for us to use without paying out of pocket, which definitely becomes tricky. And so the military guidelines are, when it comes to obesity, anybody over a BMI of 30 would be considered obese. And then from there, you have that conversation of, I'm looking at a patient and I'm thinking, okay, is this somebody that I can truly get down without medication and get down relatively quick, that we aren't worrying about a lot of long-term side effects from chronic obesity? Or is this somebody that I'm going to be dealing with their obesity for quite some time? And the more time they're obese, the more risk they have of putting on more weight, the more risk they have to their cardiovascular system, their liver, their brain health, all that stuff. And so, yeah, if I've got somebody who's teetering at 30, I'm probably not necessarily hopping to one of these medications. Plus, with the military, I can't just hop to this medication. I have to try a few others. And usually I've had pretty good success with a couple of those other medications that work in different ways. A few times I've had to come then to the Ozempic type medications. But like you kind of brought up, is this somebody where you're looking at somebody who's a BMI of 40 or 400, they're over 400 pounds. They've got a lot of health issues. Then yes, that is definitely something that kind of triggers my thought process a little more. Is, do I already have hypertension, that I know that they've got chronic cardiovascular disease? Do they have high cholesterol? And I know that we're just adding on things that increase their risk, and obesity just across the board increases cardiovascular risk. Then yes, I'm going to fight to try and hop to one of these medications like your Ozempic, your Mounjaro, things like that are approved for weight loss in obesity. So that's where I'll kind of play into it. The other side then is the cost. Ozempic is somewhere around, like, depending on the pharmacy you buy it from, if it's out of pocket, it's somewhere around $800 to $900 a month.
Oh, wow.
Which is, it's 4 shots or 1 shot every week. So essentially 4 shots worth would be roughly almost $8 to $1,000 a month, just for weight loss, if we couldn't get insurance approval. So I've had that conversation because people don't want to jump the hoops of the other medications because they've heard from their friends that Ozempic works so well. I lost weight so quick. I just want to be quick and easy and lose my weight. And then I feel like I'll be more motivated. And I have to have that conversation of, look, insurance won't cover it. You could be looking at $1,000 out of pocket every month. Is that something you can manage? So that's a conversation I've had a few times. I've yet to have a biter on one of those.
Oh, interesting.
And so just one quick follow-up is that, so let's say that someone is a BMI of 31, has disposable income. Is there anyone you would say, hey, still, you shouldn't do this? Like, because of the medication itself, what are the downsides of taking that you would say, hey, still every other factor is cool, but I still wouldn't take this because of XYZ from the medication?
And before you answer it, what I would say, because what was interesting on your previous response was that it sounded like to me the negative side effects of Ozempic are because proper decisions are not being made while on it. That's what it sounded like. I'm not trying to put words in your mouth, but like, hey, if you are on this drug and you're eating small, frequent meals that are good for you, right? Not super high fat and all the things you listed, it sounded like you're not going to be nauseous. You're not going to be vomiting. You're not going to be these things. So that,
right.
Because it sounds like a miracle drug right now. And I just you know what I mean? Like, the way it's being just talked about right now, I'm like, well, then everyone who should just be on it, who's 10 plus pounds overweight. So I'm like, is there any downside to taking it?
Yeah, there are definitely some downsides. For one, nausea and vomiting is by and large the most common. And I have seen some cases where people get into a little bit of trouble because, either it is truly they are following our instructions and they just cannot tolerate it. And they get to the point that, okay, I've dehydrated myself from vomiting, or I've got diarrhea, which is another common side effect. Then now I'm in the hospital, or I'm at least in the emergency department and I need IV fluids. Then that's definitely, if you've ever had that, that's something where I consider and say, okay, let's switch medications. Let's look at other factors. Not something that I would necessarily say is an absolute contraindication, but people who have a history of nausea and vomiting, I definitely have a prolonged conversation with them about it and might try and start at other points, other medications before trying one of these, just because it could definitely increase that risk of having those cycles of nausea and vomiting, which, you think like, oh, wow, you could nausea and vomiting. It's nothing crazy, but I've definitely had people who have prolonged hospital stays, trying to control it with a bunch of other medications, trying to then stay on top of it with their fluids, managing their electrolyte balances. It gets pretty complex. So that's definitely one thing. Another thing that these medications do have a warning for is there is a risk of acute pancreatitis, which is inflammation of the pancreas. The thought behind that, though, and there's not a lot of great data to support that these medications truly cause that. But essentially, it's just that from the theory behind it is that either, your diabetes or your obesity has already inflamed the pancreas and it's in overdrive, that some of these other nausea, vomiting things can potentially barrel roll into pancreatitis. So there's the warning that it can cause it. And, I've had a couple people who come in and they have this medication and we immediately go, okay, let's stop this medication, get them squared away, get the pancreatitis under control, and then maybe consider a different medication. But newer data is coming out to suggest that these may not be the sole culprit to cause that. So we'll see what further research shows. Otherwise, there are some other black box warnings, absolute contraindications for these, like people who have a family history of like certain thyroid cancers or people who have certain thyroid conditions. They actually say not to use these because it can significantly increase your risk of those thyroid cancers or thyroid conditions. One of them is called medullary thyroid carcinoma. And there's actually like a familial syndrome that's got a risk of that too. So anybody that would have that in history would be an obvious don't do this. But those are really the big things. There's even data coming out to suggest that these have a lot of great cardiovascular benefits, potentially due to weight loss. But there is also some protective effects over the cardiovascular system. And so a lot of new research is being funneled in to try and figure out, like, is this something we could use in somebody who maybe isn't obese, who maybe doesn't have diabetes, but has cardiovascular disease? Like, would that be an approved option? So we'll see. But those are usually the biggest side effects and biggest things I'll talk with people about, like, hey, this drug probably isn't for you.
I got one more, and then I want to make him quit working, and then we can just have fun and talk all the stuff you want to come on the podcast for. But I'm always interested when I get I do a nutrition consult for someone, or I have someone in the gym, and alcohol is a huge factor, right? And when you start to like peel back the onion, it's like, brother, you're drinking 8 beers a night. Like, of course, right? And so it's usually an easy win. Like, I actually love when I get a casual beer drinker on like a nutrition consult, because I'll be like, hey, only drink beer on Fridays, and, or, some kind of like simple rule to follow, and they'll just start shredding pounds. And then they realize, what that does. But my question is, you talk about, hey, small meals, maybe not high fat, these things that Ozempic gives you these problems. What if you have, because a lot of overweight people that I see, the problem is actually alcohol consumption, which leads to all kind of other medical conditions I know. But do you see negative side effects for, people that are drinking and taking this?
I've never actually seen a specific case where somebody was drinking and had this, but I've seen plenty of cases of alcohol-induced, you name it, pancreatitis, nausea, vomiting, X, Y, and Z. Sure. And so that is definitely on almost everybody that I see for an annual physical. Even if, they're coming in for something else, sometimes if I've got enough time, I'll definitely probe them to try and figure out where their alcohol level is, how much they drink, is it per week, is it per day? And then I'll dive further in, because that is one of the easiest things to try and peel back and just say, look, these are empty calories. If we can cut down on this, maybe not 4 beers a night, maybe 1 beer, and then maybe 1 beer every other day, then maybe 1 beer a week, whatever. Right. And they start seeing those results. And the ones I've had, it's impressive. That being said, trying to convince somebody, especially a potentially retired military member or somebody else who's undergoing a lot of stress, is a different story. Good luck. Yeah, definitely.
Yeah. No. Okay. Great. That's good. Yeah. No, Jeff, take it away on the career stuff and all that, and then we'll talk sports, all that kind of stuff. Thanks. That was super.
That was very helpful.
Informative. That was great. That was great.